Hey everybody, welcome back to another On the Couch with My Food Religion. Today I am joined with the awesome Lara Briden, who is a naturopathic doctor, and we're going to be talking all things women's health and hormones, and particularly diving really deeply into birth control and hormonal contraception, because I think it's such a big topic that just isn't spoken about enough. And I don't think that so many young women or older women even are aware of the side effects and all the stuff that goes along with hormonal birth control. So the first thing I would like to ask you though, Lara, before I get you to tell everyone a bit about yourself, is what are you digging at the moment?
Well, truth be told, I'm pretty interested in menopause these days, which is obviously a bit beyond our current topic, but I'm almost 50. So I've been reading about, I'm working on my second book on perimenopause, menopause. I've been reading about the evolution of menopause and why we do it, and it's all very cool. The body has a plan. It's menopause is not an accident, put it that way.
That is awesome. You know what? Again, I feel like this is probably something after your next book comes out that we should talk about again, because I think it is something that is so important. And so many women just think that that period of menopause means that they have to go through all of this myriad of symptoms that they struggle, and they struggle so much with. Whereas, like you said, this is a natural evolutionary process. There's a reason it happens. Our bodies don't do shit for no reason, do they?
Exactly.
There's a reason this happens. And just like it's not normal to have, terrible PMS or painful periods or all that sort of stuff, it's also not normal to have these menopause symptoms that are unmanageable, is it?
Correct. I mean, and fortunately, there are lots of things you can do, including sometimes some of the natural body identical hormone treatment, which I do describe in my previous book, and also I'm talking about in the new book. But lots of lifestyle things you can do, lots of diet changes and simple supplements that can help with both menopausal symptoms and period symptoms, of course, which is the topic of today.
Yeah, absolutely. So as usual, guys, the materials and contents that we discuss are recommended for general information only. We are going to go through a lot of the questions that you guys submitted at the end. And obviously, Lara is not individually seeing anybody here, so she can't give specific advice, but she's going to do her best to give you some really general advice and some great places to start. Oh, sorry. I have the flu. So what I'm into right now is Armour Force. All of the Armour
Force. You're doing a podcast while you have the flu. We could have rescheduled, but I mean, good on you for.
It's all right. We will power through. We'll power through. I'll try not to have the black lung and die over here. So, Lara, can you please tell everybody a little bit about yourself and your background?
Yes. So I actually started out as a biologist, which is why I'm quite interested in the evolutionary biology side of things. That comes out in some of my work sometimes. And then I trained as a naturopathic doctor many years ago. I graduated almost 25 years ago in Canada. And about 18 or 19 years ago, I moved to Sydney and worked as a naturopath in Sydney for, many years, until actually just this year I finished up, and I'm now working only in New Zealand. And I'm also the author of Period Repair Manual, which came out about 4 years ago. This is the second edition. It came out middle of 2018. So yeah,
awesome.
It's been great. Yeah.
So obviously you've got that real science sort of side to your brain. Any particular reason that set you on the path of naturopathy versus medical?
I think, and what I describe in the introduction in my book, and this is basically what happened, because I was a biologist, I realized that biology has a plan. The bodies work in a certain way, and I was really drawn to the fact that the body can heal itself. If you just give the body what it needs, a lot of the time it knows what to do with that. Not saying there are not exceptions, of course. I mean, there's some diseases that are outside of that, but for many things, functional things, especially many things to do with periods, there are lots of things we can do that work with the body's biology rather than against it. And I think, that was my initial reason for going this route.
And so you have a particular interest and passion for women's health. You've written a book called The Period Repair Manual.
Yeah.
Did that stem from your own struggles with hormonal imbalances and things like that?
No, it came from my patients. It came from literally thousands of patients, and hearing their stories and seeing what worked for them. And just over the years, learning more and more about kind of what works for periods, and eventually me needing to put that into a book. My own periods have been fairly uneventful, I guess. I mean, not perfect, of course. Like I describe in the book, I've of course had PMS sometimes, and but yeah, fortunately, I haven't had to overcome any specific period problems myself.
And look, do you have PMS sometimes, or are the people around you just assholes sometimes?
Exactly. Well, I talk about that. I talk about that in the book, actually. Women can get emotional. That doesn't mean we're like, I don't know, it doesn't mean we're hormonal just because we have emotions about things.
It just means you're being a dickhead and I'm being triggered by you.
Exactly.
So I would love to get into the topic of hormonal birth control, which I know is a massive topic. But I think for so many young women, and I think women in general, particularly even as they kind of get to that mid-age, they've got, they may have had children, or they're coming off the pill to have children, or they've got PCOS symptoms or PMS symptoms or heavy periods, and the answer just seems to be go on the pill. Sorry.
Poor you. I'm quite worried about you. But yeah, we'll power through. I should try to do most of the talking, so you can just rest your poor throat there. Right. So the question is that the question? Like, why is the catch-all prescription for everything to just go on the pill?
Absolutely. Okay. And what's the risks with that? Like, why is it just, here, take this Band-Aid and forget about the underlying root cause? Just Band-Aid this, because the problem's still going to be there when you eventually get off the pill one day. And what are the different types of hormonal birth control? Is there any that are better than others?
Okay. Well, let's start with this. Almost all types of hormonal birth control, except for the hormonal IUD, we'll leave the hormonal IUD for last because it's a little bit different. But every other type, whether it's the pill or the ring, or the injection or the implant, to some extent. Let's start with the pill and the ring, because they're very similar in that they shut down the menstrual cycle. They switch off the main event of the menstrual cycle, which is ovulation. Ovulation is why we have a monthly cycle. It's all about ovulation. I make that pretty clear in Period Repair Manual, and I've spoken about that many times. And contraceptive drugs switch that off. And then in the case of the pill and the ring, they replace what was your menstrual cycle with a drug-induced bleed. So one of the things to understand is that pill bleeds are not periods. So one of the first things to understand is the pill cannot and never could regulate the menstrual cycle. That was an impossibility. That was a weird thing to say from the beginning. I think that when they first said that, we're going to give the pill, wink, wink, to kind of normalize or regulate the cycle, that those doctors back then didn't mean that. That was just a way to really prescribe the pill for preventing pregnancy in a time before it was legal to do that. So the pill cannot regulate periods. It shuts them down. And there's real problem. My biggest problem with that is that, particularly in young women, if they start the pill at a young age, say as a teenager, shutting everything down prevents them from the very important process of maturing the menstrual cycle. Like, here's an example. We know it's very clear that most teenagers or young teens will go through a temporary phase of PCOS, which would be higher male hormones, irregular periods, maybe having cycles where they don't ovulate. That's a pretty normal part of the maturation process. And normally, if the cycle is allowed to mature, girls move past that and they start making more estrogen and progesterone, and that suppresses testosterone. We're talking about PCOS now, and they can essentially outgrow PCOS in some situations. But if you shut it all down with contraceptive drugs, then, as you say, you're really just masking it, and eventually the day will come when a woman wants to come off the pill for whatever reason, whether it's to have children or really just to take a break from the drugs, and then has difficulty not suddenly, but the difficulty's been there all along, getting her cycle going. So, and also can sometimes get a rebound of the PCOS symptoms, the male hormone symptoms, particularly skin. So that's an example of where the pill really fails in trying to treat something like PCOS or irregular periods. Should I keep going? I'm going to give you a chance to ask a question, but I'm also worried that your voice is.
No, you're good. Keep going.
Keep
I'll
going.
put my hand up. I'll put my hand
Okay,
up.
right. You put your hand up when you're ready to ask a question. Okay, so the pill induces a bleed, basically, whenever you take the sugar pills. It's dosed traditionally. Oh, yep. Go ahead.
Yep. So I've heard of a lot of people when they have the pill, and I am absolutely guilty of doing it when I was on the pill, of skipping your bleed. Now, is that safe? Is that not safe?
It's totally fine. It's totally fine.
Because it's not even real.
No, it's not a period. You don't have to have a monthly pill bleed. You can really just, I mean, eventually, if you don't have any bleeds, you'll start to get some breakthrough bleeding, which is not nice. So they need to have a bleed. It's the uterine lining shedding, and but the timing of it doesn't mean anything. So no, it does not have to be 30 days according to the package. It means nothing.
Yeah.
So that's that.
Okay. As you were.
Yeah, the bleeds on the implant or the injection are different in that there's no induced bleed, obviously. What's happening in that situation is that ovulation is still suppressed. So there's no proper cycle, as in there's no proper like luteal phase, like ovulation, and then the second half of the cycle. Instead, some women will get semi-regular bleeding. It's really just what's called breakthrough bleeding. So it's really just, there is some estrogen still happening, so you get a bit of buildup of the lining and then shedding.
Yeah.
I promised I'd leave the hormonal IUD till last. So it's a bit different in that it does not always suppress ovulation. So you can, if you're having a bleed with the hormonal IUD, it'll be light because it lightens periods or lightens bleeds. They're potentially still cycles. So I described that in the book. So there are potentially cases where I think the hormonal IUD is required to help with endometriosis or lighten periods, and it's probably the lesser evil of all of them. But just to be clear, I keep saying the word contraceptive drug, and that's because it's been quite a while since I would ever allow myself to say the word hormone to refer to those drugs, because they're not. So we talk about, progesterone only pills and the progesterone in the IUD. There's no progesterone in any of those methods of hormonal birth control. They're progestin drugs. And that's actually a big deal, because we're seeing now more and more from the research that progestins, a synthetic version of progesterone, has a very different effect on the brain than progesterone. And that's why women on hormonal birth control have been shown to have altered brain structure compared to women on the pill, have an increased risk of anxiety and depression. A lot of it's, I think, to do with that difference between progestins and our own hormones. Yeah.
And so how did we get to this place that the answer to heavy periods, painful periods, endometriosis, PCOS, pretty much anything that's not a bang on the knocker 28-day cycle with no, anything else, how did the answer to that become take this birth control pill?
Well, there's no question that those drugs erase symptoms. They erase pesky symptoms. I can totally get why doctors love it, especially when they don't have anything else. This is the problem.
Yes. So that's the problem, is that they don't have anything else. They don't have the time to deal with the root cause of this problem.
It's that they don't have time. It's also that the research hasn't been done on the menstrual cycle the way it should have been, because we've been locked in this paradigm for the last 50 or 60 years. Oh, well, you just shut it all down with these drugs. Period problems, the solution is don't have a period, basically. Have a pill bleed instead. Just to put it in another explanation, shutting down ovulation with contraceptive drugs means shutting down hormones. It essentially, you could say it induces kind of a temporary chemically induced menopause state, which is why women on hormonal birth control have vaginal dryness, for example, low libido, and changes to their vagina and vulva and bladder, which are similar to what happens to women after menopause. So that shouldn't be happening to a 22-year-old woman, if you know what I mean. Like that is not good for her body. She needs that. She needs her own estrogen and her own progesterone for lots of things, not just for a healthy vulva, for one thing, but also for brain and mood and muscles and bone health and long-term health of heart and cardiovascular system. Those are all the things that our own hormones are good for. And the endocrinologist, Professor Geraldine Pryor, who helped me with Period Repair Manual, has a great quote that I often share with people, which is that women benefit from 35 to 40 years of natural ovulatory cycles. Ovulatory means ovulation has occurred, not just for fertility, but to help to prevent osteoporosis, heart disease, dementia, and breast cancer. And by breast cancer, she's talking about the benefits of our progesterone that we make after ovulation having arguably a breast cancer prevention effect on the body.
Because I think so often people just think about fertility and having a healthy cycle as I only need that if I want to have a baby. But really, having a healthy cycle is all about the health of your body. Like if your periods are all fucked up, there's way more going on with your body than not just being able to have a baby.
Have you heard me say, I've said it a few times, that to say to women, you don't need your hormones until you're ready to make a baby would be like saying to men, you don't need your testosterone until you're ready to make a baby. And I don't think that would go down very well with men. That would never be said to them. I mean, obviously they benefit from their testosterone in terms of mood and muscles and all of those things. So do we. We benefit from our own hormones. It's no different.
There's a reason they're in our body, isn't there?
Yeah.
Oh, so could you please talk a little bit about some of the side effects of,
contraceptive drugs?
Yeah.
Mood. I'd say depression is the biggest one. Not to say that every woman who takes contraceptive drugs will develop depression, no. But the risk is, I think, at least 3 times higher, especially in the teenage age group. And it's always missed. So a common story I'll hear is, okay, you go on the pill or get the hormonal IUD or something at 15, 16, and then 9 months later, suddenly needing an antidepressant or having to, miss school because of mood, and nobody's connecting the dots, unfortunately. Well, they haven't been until recently. There's been a couple big studies making that link between all types of hormonal birth control and mood. And I think hopefully doctors in future might start to make that connection. Because what a shame to put someone on an antidepressant if really they just need to get off the pill.
Oh, and isn't it just inappropriate? Like, I think that the pill is just prescribed so inappropriately these days. Do you think doctors, general practitioners are becoming more aware of the side effects of the pill and are less quick to just go, here, have that?
Many of them are, yeah. I think in their defense, the narrative that they were taught and that they operate under is that the pill is fine, that it has a safety record, that it's been tested extensively and it's safe. And that's actually not true. I mean, yes, it has been tested to some extent, but not in terms of things like mood until quite recently. The other one symptom side effect that young women can experience, which is actually a really concerning, troubling one for many of them, is hair loss. So here's an example. The progestin drug, levonorgestrel, which is the one in the hormonal IUD, one of the implants, quite a few of the pills, is derived from testosterone, the male hormone testosterone. So it's actually more similar to testosterone than it is to progesterone, which is why it can cause breakouts and hair loss. Now, on the topic of breakouts, I'm just going to keep talking because of your voice. On the topic of skin, of course, that's the reason that a number of young women are put on the pill, is to help with their skin. And certain of the progestin drugs do definitely help with skin. But I guess the way I would see it is that's just overkill. You don't need to shut down a young woman's hormonal system just to help acne. There are lots of other things you can do that I describe in Period Repair Manual, and I also present in a blog, one of my blog posts called How to Prevent and Treat Post-Pill Acne. There's very simple things you can do. I mean, obviously changing your diet, removing cow's dairy and sugar, taking zinc. These are all very simple things that in my experience with patients, most young women would their skin will be fine, after 6 months of doing that. Yeah.
Absolutely. So, I mean, depression and mood disorders are something that, you know, we're hearing so much more about now in terms of these hormone, like birth control and contraception. Yeah. What about things like nutrient deficiencies? Like that seems to be a really big thing as well.
It is. You know, I guess the reason I don't speak so much about the pill-induced nutrient deficiencies, I'm trying to draw attention to some of the bigger things, the way it's induces like a chemical menopause or castration, basically, robs the body of hormones. But yes, it can cause nutrient deficiencies, I think primarily because it affects the microbiome. So you've probably spoken to lots of guests, I'm sure you know all about the microbiome, the good bacteria that live in our gut. They're affected by the pill quite strongly, actually, and not in a good way. So I think that's part of what's going on. And yes, we can come in and I guess supplement some of those nutrients have been depleted by the pill, but in my thinking, it doesn't really address the issue, the main issue.
Yeah. No, I mean, it's not addressing the underlying cause, is it? I mean, if the underlying cause could just be fixed by taking yourself off the pill.
Yeah.
So you briefly mentioned hormonal acne, and particularly in young women. What would be your top 3 things for those people to do to really start to move the needle in terms of helping to do that naturally before they go and think about getting on the pill?
Zinc, number 1. Yeah. Zinc, especially for any young woman who's vegan or vegetarian. I'm just going to say for the record, all vegans need zinc and probably vitamin A, preformed vitamin A. Yeah. It's becoming more popular, unfortunately. Vegan diet.
It's a very, very interesting
yeah, which we really won't go into because I do get in trouble if I talk about it too much. But we'll just so let's say zinc.
Any particular form of zinc, or just any zinc would be fine? Well, and do they need supplement at a certain dose or every day?
The standard dose that I talk about in my book is 30 milligrams. Yeah. So that's a pretty standard. I mean, preferably a better quality capsule or a liquid rather than a tablet. Just it's more absorbable. Yeah. Then the next thing would be, in general, no cow's dairy. There are probably a few exceptions, but I'd say most people, their skin's going to be worse for dairy. But that includes yogurt, cheese, ice cream, but usually sheep and goat products are okay, and butter is fine.
Yeah, but it would be a case of just take it out, hey? Like take it out for 30 days and see what happens, and then see how you do with sheep or goat. Yeah,
for skin, 30 days might not be quite enough, but yeah. And then the third thing in terms of diet is sugar for skin. And by sugar, I am also referring to like date balls and all the dessert type, natural dessert type foods.
Healthy treats.
Yeah, I've had a few patients where that is where it's going off the rails, basically. Yeah, they're doing lots of other things, but then I find out they're having these like smoothies and date balls and yeah, that is, especially if you're already dealing with a post-pill skin situation or a skin situation, you really need to dial that back until skin is better. And then you could probably find an amount that you can reintroduce that won't flare it up again. So it doesn't mean you can never in your life have dessert type foods again, but it does mean take a careful look at that and really read the label. Because I had a patient a couple of weeks ago who she was showing lots of signs that she was eating sugar. So in her case, it was more insulin resistance and weight gain rather than skin. But I said, okay, you have to be eating sugar. And she's like, I'm not. And she described her diet. And then she mentioned that she's having these cacao drinks. And I'm like, well, what's that? She's like, oh, it's just cacao. It's only cacao. That's the only ingredient. I'm like, no, I don't think so. Because you can't just drink cacao. Like that tastes super bitter. Like you would. Yeah, you can't just. She's like, oh, I don't think so. She gave me the name of it. And I looked it up online. And it, of course, had, 28 grams of sugar per serving in the form of agave or something, some various coconut sugars and things like that. And I said to her, that's sugar, and she's like, well, that's a problem because I'm having 8 of those a day. So I'm just pointing out, like, you can have a situation where something you think is okay, this food is fine, and then
and it's healthy. I'm not doing dairy. I'm not doing grains. I'm not doing whatever. But I think, and that's something that's really difficult for people too, is that they think that, because it also could just be they're eating so much fruit as well, couldn't it?
Dried fruit can be a problem for skin.
Yeah.
I draw the line. I'm hesitant about saying anything bad about whole fruit. I
Yeah.
think it depends. If you have a digestive problem or a fructose absorption problem or malabsorption problem, then yeah, fruit can be a problem. I think for most people, though, it's more dried fruit, fruit juice, that kind of thing.
Yeah.
Sweeteners. Yeah.
Yeah.
Put it this way: if it tastes sweet, it's dessert. So there's a reason. Like if it tastes sweet, you have to figure out why does it taste sweet. Like if it's something like stevia, okay, that's different. But if usually it's this actual natural sugar of some kind.
I would love to know your thoughts on stevia.
Well, I think it's fine. I mean, I think it's fine. But I mean, I'm open to. Do you have other information to?
No, I just think it tastes nasty.
Oh, that tastes nasty, right? Yeah.
Yeah, like I think, stevia comes from a plant. To be honest though, pure stevia should be green. It should not be white. Because it's the ground leaves of a plant. So if you do get pure stevia, it's like a dirty green.
It's processed. Yeah.
Absolutely. So, I mean, is it bleached? What's going on? Like, why is that fluorescent white? But also, I just think it tastes fucking awful. Like, I would far sooner, if I'm going to make a batch of, paleo muffins or something like that, I would far sooner add a couple of tablespoons of raw honey throughout a whole batch of muffins and just be done with it. Get some of the great nutritional products, things, and get on with it rather than add. And I know stevia is not an artificial sweetener, but I just think it tastes awful.
I'm with you. I guess we'll talk just briefly a bit more about sugar. I mean, I think yes, there's definitely a threshold. There's an amount, and it like a lot of people can certainly have, as you say, like a teaspoon of honey spread through the whole. That's not going to be a problem for anyone.
Yeah.
I think if you go much beyond, like up sort of above a certain threshold of fructose, though, I think it really depends on how insulin sensitivity and kind of the insulin situation with people, which we can get into, or we can just
And I mean, it depends as well. Like if you're in the middle of a health crisis and you're trying to get to the bottom of an autoimmune condition or a hormonal disruption, you probably really just need to rein it in. And muffins, probably not what you need to be eating. You probably need to be focusing on your veggies and some low sugar fruit and good quality proteins and healthy fats. So I think it's a case of where are you at with your health.
Yeah, with my patients, especially if there's sugar cravings or sugar addiction, one of my first step, rather than saying, okay, quit all sugar, because that can be quite hard, my first step is to put in place things that nourish the body and stop cravings. And so that would be pretty high dose protein, with especially in the morning, but with every meal. It's highly satiating, combined with magnesium. That combination, basically the strategy is to convince your body that it's full, basically. Give it everything it needs to feel, okay, yeah, I feel good. I don't need to reach for anything else. And then suddenly the sugar becomes a lot less necessary, especially once you get through those first couple of days of withdrawal.
Yeah, and I think so many people are used to this standard Australian, standard American diet, which is highly processed carbohydrates at every meal. You wake up in the morning and you have some sort of junky, highly processed carbohydrate cereal for breakfast. No wonder you are starving again 2 hours later because you're on this massive blood sugar roller coaster. You hit the bottom of that and your body's going, quick, get me some more sugar. So you go and get a muffin or some other sort of junky carb. Again, so I think this is where this whole eat every 2 hours to keep stimulating your metabolism has come from. It's because we're on this blood sugar roller coaster. Everybody needs to eat every 2 hours because they're so fucking hungry all the time. They need to try and regulate this blood sugar. And they've all been terrified of fat.
Yeah, no, I agree. So I mean, just sharing my own breakfast, I usually have just leftover dinner from the night before, which would include some meat or chicken and a few veggies fried up, and sometimes there's a little bit of rice or potato if there's some left over. But having that solid protein in the morning, and it could be eggs, it could be protein powder if you want to go that direction. It's a make or break thing. I just find it. I've had so many patients who've said to me that changing that one thing, changing to having protein in the morning, did everything in terms of their energy.
Yeah. Oh, absolutely. I think often what comes along with that good quality protein seems to be a good dose of healthy fat as well, especially if you're talking about something like eggs as well. You're getting that fat, which is so nourishing and so satiating. Like, I think our
Yeah.
bodies have been starved of fat for the last 20 years because we've been scared that fat was going to make us fat and give us heart disease.
Yeah.
So we've been eating this highly processed chemical shitstorm, no fat garbage. And all our body wants is fat because it tastes delicious and it keeps us full. So
Yeah.
we can go, 3, 4, 5 hours between meals without thinking, I need to eat again because I'm going to like kill somebody.
For what it's worth, protein is more satiating than fat. So
Yeah.
I'm more kind of in the protein camp. I'm not anti-fat, definitely, but I think sometimes one of the reasons we think fat is so beneficial is that it goes along with protein, like eggs and meat and goat cheese and things like that.
But I mean, nature's not stupid, is it? It packages things together. So, I'm not saying everyone needs to go and like deep fry their eggs in coconut oil, but your eggs come with this great source of protein and some great healthy fats as well. So I think it's something that, like you said, I think having some protein, particularly first thing in the morning, just makes such a difference to that stabilization of your energy levels.
And it doesn't have to be first thing. It could be like 9 or 10. So that's just a section I've just written in my latest book, is just there is some value to probably eating breakfast by 10 a.m. But I think for many people, you don't need to force something earlier. Like, you definitely, if you have to be out the door for work by 6:30 or 7, you don't need to eat anything at that time. You could wait and eat a bit later when you're feeling more hungry.
Yeah. So what's your thoughts on fasting? Do you think that has a place in helping to regulate hormones?
If we're going to call 16-hour overnight fasting, then yes. I think especially I guess, depends on age and situation with insulin, but let's take the 45-year-old woman, that's the topic of my next book, who has insulin resistance and maybe not the greatest digestion. Yeah, there's no reason for her to be having breakfast at 7 a.m., especially cereal or something like that. She's better off waiting until she's ready for food, which might be at 9 or 10. But I think going much beyond 10 a.m. in terms of fasting could be a problem for circadian rhythm, because protein also signals do you know about, your listeners, I guess people would know about circadian rhythm, our body clock. It's really important for hormones, for energy, for immune function, for the gut. And we signal circadian rhythm with both light and dark and the timing of protein.
Yeah. Interesting.
Yeah.
So, and I think as well, fasting and intermittent fasting, we're not talking about a 24-hour, 48-hour, 7-day fast. We're talking about intermittent fasting, which is just a period of time where you are not eating. So it might mean having dinner at 6 o'clock at night, and like you said, not having your breakfast until 10 o'clock the next morning. And just having that. I mean, everybody fasts. If you don't get up in the middle of the night to eat, you're fasting, and you will probably be doing it for 12 hours because you're not getting up to snack in the middle of the night. So for most people, it's just a case of dragging that out a little bit longer. And that might need to be a gradual thing. Hey, it might just need to be let's just firstly make sure that last meal we have is really nutrient dense, lots of good quality protein in there, lots of veggies, lots of fiber, so that we're actually not waking up in the morning ravenous thinking that we're going to kill somebody.
Yeah. And again, it depends on the person. So the women under 30 who are already maybe tending to undereating and have lost their period to undereating, don't do what we're talking about right now. I think in your case, you need to have, breakfast. When you get up, you need to have 3 meals and maybe a snack in there. I worry a little bit when in a lot of these conversations about diet, where we're talking about one group, maybe the insulin resistant 40-something-year-old people, and then the 20-something-year-old young women are following that advice and losing their periods. So that's something called hypothalamic amenorrhea. I'd always just like to plug that or mention that whenever I can, because they're kind of being left behind by a lot of the advice that's really geared more to men and to older women. And young women need more food and can lose period even if they don't get enough food. And one thing I'm going to just say here is that for any of your listeners who have lost their period and are not sure why, just take care that there is something happening right now where it's quite common for women with hypothalamic amenorrhea or undereating to be misdiagnosed with PCOS, because doctors are relying on the pelvic ultrasound and the finding of polycystic ovaries to diagnose PCOS, and PCOS cannot be diagnosed that way. PCOS is a real thing that is associated with high levels of male hormones and irregular periods and sometimes insulin resistance. But just having polycystic ovaries on ultrasound does not mean you have PCOS. And just really take care. My last Instagram post, well, I don't know when this is coming out, but an Instagram post I did around the middle of October was around comparing and contrasting PCOS and undereating and kind of what that looks like. So I hope that will help someone.
No, I think we've actually got some questions about hypothalamic amenorrhea anyway. And I think as well, fasting is one of those things, particularly for women, you just need to be really careful about the rest of the stress in your life as well, because not eating is a stress, which is why particularly young women, if they're under eating, they will lose their period, because your body is like, okay, shut down reproduction because there is some sort of crisis going on here. We are in a stressful situation. So reproducing is the last thing we need to do. Let's shuttle all of our energy to everywhere else.
Yeah, it's a bit more than that with young women. It's not just that it's stressful, it's that their hypothalamus, or the command center in their brain, perceives, quite rightly, that there is not enough food to make a baby. Like literally not enough food. Yeah. And it shuts down hormones. Now, just to compare and contrast, men's hormonal system doesn't do that. Their hormonal system's never going to go, oh, there's not enough, food to make sperm. Like they don't have that. They don't require 75,000 extra calories to make sperm, basically. So, and to make testosterone, they're in a very different situation. And the other interesting thing about men versus women is that in general, fasting for men reduces stress hormones. For women, it increases them. So really take care. Next time you're listening to some men talk about what works for health, they really mean what works for men.
Yeah, absolutely. And I mean, stress could be that you're having a stressful time in your relationship. It could be that you're not getting enough sleep. It could be that you are over-exercising. And whether you perceive that over-exercising as being too much, if your body is perceiving it to be too much, it is too much. And I think a lot of people don't realize that even though exercise is healthy and it's a great thing for us to move our body, sometimes it is just too much for our body at that time. And I remember when I was trying to fall pregnant, I came off the pill and it took me probably 9 months to actually even get a period back. And then in that time, I had the worst hormonal acne. I'd never had acne in my life, never had it as a teenager. And I had this hormonal acne that was just, I seriously would just about cry every day, just thinking, what the hell is going on? I'm a 30-something-year-old woman and I rarely wear makeup. And I felt like I could not leave the house. I just, cystic, horrendous, painful, it was fucking awful. And at the time I was doing CrossFit and I had my nutrition so dialed in. I could not have had anything more dialed in. And I just didn't realize that it was too much. Everything was too much. I needed to stop doing CrossFit. I needed to just go for some gentle walks and meditate and calm down because my body was so stressed.
It's that. It's also, there's just a withdrawal syndrome from some of the contraceptive drugs that causes acne, basically. So sometimes what I say to my patients with post-pill acne, I talk about it in the book too, it's not a problem with you. It's a problem with the drug that you were given and are now trying to withdraw from. It can, like you say, like it happens in women who never had skin problems before, suddenly, having to go through that process. And it takes about 6 to 12 months. Usually post-pill acne, trying to come off Yaz or Diane, or what were you on?
Diane.
Yeah, Diane's the worst. So that's a drug called Cipterone, which suppresses male hormone, androgens and skin oils to childhood levels in women, which is not good because that's not normal for an adult. And so the body upregulates skin oils and androgens, and then in response to the drug, and then when you stop the drug, they just they're upregulated, so they stay upregulated for 6 to 12 months. And usually post-pill acne coming off Diane or Yaz or Yasmin those drugs peaks. It usually peaks at about the 6-month mark. Was that you? Like at about 6 months, you're thinking, I don't even know what to do anymore. I'm just going crazy. And then it usually starts to improve on its own anyway, but there's other things you can do to help with that.
Yeah, it was terrible. And it actually took me over 2 years to fall pregnant. Had one miscarriage beforehand, and was working with a naturopath at the time, and that was due to really low progesterone as well, which again I think was just a lot of the stress that I was putting my body under, mental, emotional, but also, you know, the physical stress of thinking that I needed to do all this exercise and keep my body really strong and healthy, whereas what I really needed to do was just calm the fuck down.
Yeah. No, it's not an easy process for sure.
It's not at all. But I think so many people don't realize how difficult it can be. And I think for such a long time, you know, we don't want to fall pregnant, and we'll do whatever that means to not do that. And then you think that you can just click your fingers when you're ready, and then it's all going to happen. And I would say for 90% of the people who I know, that's just not the case, unfortunately. You can't just come off your pill and fall pregnant and everything be okay.
What I find, just if it helps your listeners, what I find with my patients is it depends on the age it was started. Yeah. So yes, there are women out there who, especially if they started the pill later, like a little bit later into their 20s, after they'd had quite a few years of cycling to mature the menstrual cycle, then if they take the pill for a couple of years, they can usually probably just stop it and get their periods back, get their ovulations back, and fall pregnant straight away. That does happen. But the thing is, we hear those stories about those women who can just stop with no problems. And then we think that's going to apply to everyone, but forgetting that this might be a young woman who started the pill at 13, especially a strong one like Diane, which, is going to be a very different story.
Absolutely.
That's post-pill amenorrhea, or post-pill lack of periods, or post-pill syndrome, if you will. It's kind of a controversial term, but.
And then interestingly, and also quite frighteningly, because by the time I came off the pill, I think I was really starting to get my head around the fact that that was just not a great thing to be on anyway. But of course, I was seeing an obstetrician, and his first answer to was, "Oh, here, we'll just take some Clomid. Just take this to force your body to ovulate." I'm like, no, my body's not ready to have a baby. Like everything about what's going on here, my body's saying, can't grow a healthy human. Not going to happen. So let's force it to do that? I don't think so. Anyway, needless to say, I got a new obstetrician. But but it's interesting, isn't it? Like the answer initially was, here, take the pill, and then after that, okay, well, here, take some more drugs to fix what we fucked up for a really long time, and see how you go with that. And how is that going to create, you know, this healthy, thriving pregnancy when everything in your body is saying, no, these conditions are not right to grow a human, but we'll just force it. Just force it and see what happens.
Yeah, agree.
Cool.
Yeah.
All right, let's try and start working through some of these questions. So this one is how to switch from managing endometriosis with hormonal contraception to a natural method.
Okay. Well, the first question is endometriosis, which is its own podcast. But what I'm going to say is endometriosis is different from all other hormonal conditions. Yeah. In that it's not, from all other period problems, in that it's not a hormonal condition. It's an inflammatory disease that can be relatively mild or can be obviously quite serious, depending on the stage and the type. And so I would just say, like, in general, and I make this clear in my book and most of my work, I'd say for most period problems, including irregular periods, skin, mood, even heavy periods to some extent, you know, I think those are all fairly straightforward to correct, and the pill is not a solution. In the case of endometriosis, it's a little bit more complicated, and I can share this. I mean, with my patients, especially if they come to me and they have severe endometriosis and they're on the pill, I don't want them to stop the pill straight away. I don't, because potentially, if the contraceptive drugs are managing to suppress the disease to some extent, then you don't want to just immediately stop that. You need to make a plan to treat the inflammatory disease. Yeah. And I have a blog, it's in my book, chapter 9, but I have a blog post called Endometriosis, Treat the Immune System. Okay. Endometriosis is more in the category of inflammatory diseases like inflammatory bowel disease and arthritis and things like that. It's that kind of thing. So you really do need to make a plan. Yeah.
Do you think it's autoimmune in nature?
I think to say that it's autoimmune is unfortunately very controversial and not popular. So I'll say it doesn't even need to be stated as categorically autoimmune because the research isn't quite there yet, but it is a disease of immune dysfunction.
Yeah.
I'll say that. It's not a disease. Usually the hormones with, like, unless they're on the pill, obviously, but usually most of my endometriosis patients, their hormones are fine. Like, they're cycling, they're ovulating, they're making progesterone. There's other stuff going on that needs to be addressed. And so treatments would look like, just as an example, this is obviously, as we said, not a treatment specifically for that person who asked the question, but just the kinds of things I talk about in my book is endometriosis is the kind of disease where you potentially have to look at being strictly dairy-free, gluten-free, and not just dialing it down like we were talking about with sugar or just finding a sweet spot. Or no, it's because it's an inflammatory disease of an immune type. It needs to be treated kind of like you more would treat like autoimmune thyroid disease or something like that. And then there has to be some degree of gut work because the gut is very involved, and not just, the little bit of inflammation from the gut, but usually there's quite a lot of inflammation coming from the gut that may be one of the main driving sources of endometriosis, combined with genetics, combined with malfunctioning of the immune system. So that gives you a sampling. I know that makes it sound quite complicated, but I would say the starting place might be my blog post that I just referred to. We'll put that in the show notes. Chapter 9, a peer-to-peer manual, reaching out to, because I'm not the only one talking about endometriosis in this way. There's lots of other people talking about it this way, looking at, an immune modulating or anti-inflammatory strategy for the disease, combined with sometimes, yes, if required, surgery. Although endometriosis should never be surgery after surgery after surgery. And before we leave the topic entirely, I will say, for what it's worth, there's natural progesterone capsules, which are called Prometrium in Australia. Are most of your viewers in Australia or around the world?
Australia and the US.
Okay, so it's called Prometrium in both of those countries. It's called Utrogestin in the UK and New Zealand. It's the brand name. It's a capsule of progesterone, not a progestin, like in contraceptive drugs. And so Hannah's, in chapter 9 of Peer-to-Peer Manual, Hannah's patient story is one of my patients who, amongst other things that she did, she switched from Visan, which is one of the drugs that's used, to Prometrium, and was able to see some good results from that.
Awesome. So, how to manage heavy periods? My doctor says my only option is birth control.
Do you know the age of the person asking? Or
no.
Okay. All right. So in my writing, I've sort of divided. Anyone at any age can have heavy periods, obviously.
I would say she's under 30 from the
Yeah. Okay. Well, look, and the thing about heavy periods, first of all, it's about trying to figure out what's causing them. So if it's endometriosis or something called adenomyosis, then that needs to be treated as per the previous question. If some women with heavy periods actually have a coagulation or like a blood clotting disorder, that needs to be screened for, actually. But in some situations, the cause is having anovulatory cycles, or cycles where you didn't ovulate or make progesterone, because progesterone has a period lightening effect. That's one of its many beneficial effects. So if you're not ovulating, then the plan is to find a way to ovulate, which could mean addressing insulin resistance or something like that. But if there's just really no obvious explanation, then the treatments that I provide in Peer-to-Peer Manual, and also a blog post called, most of the stuff that's in my book is also freely available in blog posts. Not all of it. There's obviously a lot more in the book, but the blog post is called how to treat heavy periods with diet and natural progesterone. So I talk about the natural progesterone capsules there as well. But just in a nutshell, the diet change that works for lightening periods is no dairy. Similar to what we were talking about with the skin, but it's really to do with something called mast cells. The uterine lining is full of mast cells, and dairy, potentially cow's dairy, stimulates a histamine or mast cell release, which makes periods heavier. Plus getting your iron up. That might mean taking an iron supplement. Plus, I talk about the herbal medicine turmeric. Plus, just as a little, if people don't know this, taking Nurofen or similar, naproxen or something like that during the first couple of days of the bleed can lighten the period by 50%. So in my thinking, those are medications, obviously. That's not a naturopathic treatment. But in my big picture thinking, better to have a couple of days of Nurofen than the pill every day.
Yeah, absolutely. And at least if that helps you get to a point where you can actually manage it as well,
Yeah.
and then hopefully wean off at that point, I guess.
Exactly. Yeah.
Any long-term side effects on your health with having PCOS?
Untreated PCOS, yes. Okay, so let's just talk about that for a minute. Number one, I have to say this again, be careful. Like the first step is, do you really have PCOS? Because if that diagnosis is pretty much just based on an ultrasound, you need to go back to the drawing board and think about what that is. So let's define what PCOS really looks like. It is a condition of having high male hormones. Yeah. So there's going to be some degree of facial hair, body hair, hirsutism, or pretty severe acne, jawline specifically, or measurable androgens or male hormones on blood test. So that really has to be there for it to be PCOS. If that's not there, then it's not PCOS. I'd say that. Then if it is truly PCOS, then of course the next question, I have a flow chart I have a blog post called The 4 Types of PCOS, and I provide a flow chart there and in my book. And so the next question down, if once you decide, okay, truly as PCOS, yes, I have high male hormones, that it's an accurate diagnosis. The next thing is to understand, well, first of all, to understand that very often is a temporary situation. So it could be a situation you're going to outgrow anyway, or temporary in that you can reverse it with treatment, with diet changes. Any case of PCOS really can be reversed to some extent, some more than others. But the next question down is there insulin resistance? It's a big deal. I don't know why doctors don't test for it more, because endocrinologists do. Like the specialists understand that insulin resistance is a big driver of PCOS. Not a cause necessarily, but definitely a big driver. That means having chronically elevated levels of insulin. Yeah. So insulin needs to be measured. You can't just, if the doctor measured glucose or blood sugar and that was fine, that doesn't mean you're fine. It doesn't mean you don't have insulin resistance. Yeah. And conversely, just being told you have, polycystic ovaries doesn't necessarily mean you have insulin resistance. Like you can't, insulin resistance needs to be tested. The physical sign of insulin resistance is significant weight gain around the middle or kind of around the belly button area. Yeah. That kind of apple shape is looking a lot more like insulin resistance, but even then it's still good to test it. Yeah. And then the treatment is lowering insulin. Okay, so the question was, are there long-term health risks? The long-term health risks come from the insulin resistance. Yes. Primarily, which is reversible. So yes, untreated, doing nothing, letting insulin resistance just continue is going to have long-term health risks. The other long-term health risk, the other part of PCOS is that, not always, but fairly commonly with the hormonal condition that's called PCOS, which is actually a few conditions that are all given the same name. But if a woman is not ovulating regularly, that could be part of having what's called anovulatory cycles, or cycles where you don't ovulate. A cycle where you didn't ovulate might be one where you bleed for 10 days because you didn't make progesterone to normalize the flow, or you're having a period like a bleed 4 times a year. Those are not ovulatory cycles, right? Yeah. So those are signs that ovulation might not be occurring. Over the very long term, like over decades of that happening, it thickens the uterine lining and can increase the risk for what's called endometriosis cancer or uterine lining cancer, like over decades, right? So the doctor might say, you have PCOS, therefore you might get cancer, therefore take the pill. Sorry, I shouldn't laugh, because that's actually what they say. But big picture, yes, that's true. If you were to just continue in a state for 30 years where you don't ovulate and build up a uterine lining, then yes, that's true. Something needs to be done. But for many of these young women I see, all they have to do is find a way to start ovulating again, which usually just means changing their diet, taking some of the supplement inositol, and resuming ovulation and making your own progesterone. And then, no, you don't have an increased risk of cancer compared to other women. Yes. So
you've mentioned quite a few times that PCOS is often really misdiagnosed. So if somebody thinks that they have PCOS or has been given this PCOS diagnosis, what tests do they really need to ask for? So they need to be tested for insulin resistance. Is there any point to having this ultrasound on their ovaries?
There's no point to the ovary ultrasound.
Okay.
Pretty much. I can say that categorically. That said, I mean, the doctors like to do an ultrasound anyway to rule out other things, and fair enough. And they like to look at the uterine lining with ultrasound. And so I'm definitely not saying that an ultrasound is not a diagnostic technique for certain things. It is. But yes, the ultrasound finding of polycystic ovaries means basically nothing. Look, there's no definitive test because it's actually one of the most misunderstood conditions. And I really think in many ways that because the diagnosis is so confusing, so problematic for lots of women, that I actually think there needs to be a back to the drawing board. I think they need a new name for the condition. I mean, a lot of experts think that. The name polycystic ovarian syndrome is really problematic because it's nothing to do with cysts on the ovaries. You can have cysts on your ovaries. That's a different thing, though, right? Like the PCOS has nothing to do with cysts on the ovaries, unfortunately.
There are ovarian cysts.
No, ovarian cysts are a separate issue. PCOS is really, in simplest terms, it's just about having high male hormones.
Yes. So that's what they need to get tested for. Is they need to get tested for androgens, and they need to get tested for insulin resistance, because if the androgens are there, they also need to work out what sort of PCOS they have, whether it's insulin resistant PCOS or otherwise. Is the treatment going to differ?
Yes, totally. It's what I said before. So there's women being given, like, some women with the label PCOS have a primarily insulin resistant situation where that's the main thing that's going on, that's driving the androgens.
Yes.
Some women are more in a temporary post-pill situation. Like you're actually a situation where you had post-pill acne and no periods technically qualified you for the diagnosis of PCOS. Like, I mean, you didn't have that, but I'm just saying that's how easy it is to kind of qualify. Like if you have irregular periods and clear signs of androgens, that's pretty much all it takes now. And you can get, so you know what I'm saying, like you can have someone who's doesn't have insulin resistance, who's really just like that because she's in a temporary post-pill situation.
Yeah.
And then you can have, there's a whole different category of having higher adrenal androgens, which is quite a different situation. So I guess at the end of the day with my own patients, I tend to say, look, let's just put the label of PCOS to the side for now and just treat what has to happen. So if there's insulin resistance, then we have to reverse that. If there's high androgens, then we have to improve that. And part of the way to improve high androgens is to start ovulating again. So you can make estrogen and progesterone, which both have anti-androgen effects, anti-male hormone effects. So kind of just about treating what's going on, if that helps. And just one other thing to say about the ultrasound. I've also seen patients, especially older patients. So we have more follicles in the ovaries when we're younger. Follicles are the eggs.
Yeah.
Right. That's what they're counting when they look at these ultrasounds. They're not counting abnormal cysts. They're counting just how many eggs are there, basically. We have more when we're younger, and we have fewer when we're older. So it's possible to have PCOS as a 40-something woman and be having anovulatory cycles and have quite clear signs of androgens like facial hair, but have normal looking ovaries on the ultrasound, and then be told you don't have PCOS because that's just crazy. Like, you know, it's obviously someone who definitely fits the category of PCOS being now told she doesn't have it because of the ultrasound. So it can kind of cut both ways.
Yeah.
So I hope that's helpful. I know PCOS, it is actually one of the more confusing topics because it's been mislabeled and
Yeah. But it's a case of working with the right practitioner to deal with the symptoms of PCOS, if that's what we're going to call it, and address those things to help balance everything out.
Ideally, if you can have a practitioner to work with. I mean, with period repair manual, my hope was that some women, depending on the situation, could figure things out even without a practitioner. Because some of the treatments for PCOS are actually really simple and safe to take. Zinc and inositol are two of the big ones.
And are they things that they can take without inositol?
Yes.
Is not something
inositol is totally, you can buy that. Well, I think you have to buy it online, but it's safe, it's easy, it's inexpensive. I always feel like I'm doing a little infomercial when I talk about it. It's so great.
Yeah, okay.
And also in the book, I provide a list of questions for the doctor. So this is very important. So you would probably need the doctor. You do need the doctors to tell you try to determine if you have high androgens, if other reasons for high androgens have been ruled out, if you have insulin resistance. Those are all things the doctor needs to do. But then from there you can say, okay, so in like one of the questions, I think one of the in the how to speak to your doctor section in the book, I say something like, okay, I understand I have insulin resistance. So now, and that's probably a driving force of my androgen problems. So I'm going to work on that for a few months and see if I can reverse this. Is that okay to do? And most doctors are going to say, yeah, that's fine. That sounds like a good idea to do that. So
cool. So I'm only 17 and I'm looking into contraception. What is the best alternatives to, birth control pills?
Okay. Let's just go through kind of quick, a survey of what we've got currently. Number one, condoms. And condoms are, how this happened, I don't know. But, I was a teenager 35 years ago, 35 years ago. We used condoms at that time. Like some people were on the pill, but the pill wasn't as common then. And condoms were a thing that you could use to prevent pregnancy. Like, I don't know why that's now become not a thing. Like the young women I talk to are sort of have the idea that you have to use condoms and the pill. It's like, no, condoms work. And in the unlikely event of a condom, I guess my recommendation is have access to the morning after pill, which is really just the pill. But you're only taking it hopefully never, or maybe like once, in a few years. So it's a very different thing than taking the pill every day. So there's that. And with condoms, you really need to get one that's good quality, that fits properly. I talk about a couple brands in my book that, take some time to choose one that's going to work. It's far less likely to break or slip off if it fits properly. Which means there's actually one brand of condoms where they have 60 different sizes. So the boy has to measure his penis and find the right size. I had one patient saying, it's kind of like getting shoes that fit. I'm like, would you try to walk around or go for a run in shoes that just don't fit at all? So
that's awesome.
So that's number one. Number two, I will mention, is the copper IUD, which is non-hormonal. It's the other kind of IUD, right? That has some pros and cons. In fact, I have a whole section in the book called Pros and Cons of the Copper IUD in a blog post. So people can weigh that up. But just to, especially for the young people listening, to get an IUD put in is not surgery. I've had a few weird conversations with young women where they either never heard of an IUD or some very confused idea as to what it is. So it's just looks like an earring that the doctor, they usually have to use some form of anesthetic because it can be quite painful to put it in, but nothing is cut, or it's not surgery to put that in. And then it can be removed whenever you need it to be removed. So there's that. There's fertility awareness method, i.e., for simplest methods, is a device called Daisy, which is very popular in Australia. There's an Australian distributor. You could put the link in the show notes. Basically works with the principle, the fact of the human body, which is that as women, we're actually fertile 1 day per cycle, 1 day. But we're fertile effectively for 6 days because sperm lives for 5 days. So men are fertile every day. Women are fertile 6 days. And it is not rocket science to figure out which days. There's different ways to do it. It's called fertility awareness methods. There's different ways to track mucus, or Daisy just only relies on a temperature, has a little computer that does the calculations. So there's that. I think they claim it's suitable for anyone between, I think, the ages of 18 and 44 or something like that. So potentially a 17-year-old, I guess, might want to use condoms until she's 18 and then look at that. For what it's worth, there's withdrawal, which I know gets bad-mouthed all the time, but it actually is not bad statistically, especially if you do it correctly and do not have sex twice in a row without the man peeing first. I see your little dog.
Just getting up in amongst it.
Having a little hug. Oh, there he is. And then there are, hopefully, fingers crossed, other methods coming. So the big tragedy really is how little research there's been into other methods of hormonal birth control. We came up with basically contraceptive drugs in the 1950s, and haven't strayed from those. Like, we have different types supposedly, but they're all basically doing the same thing.
Yeah.
So I'd like to see some new methods coming. There's a new one coming for men, boys, which is a one-time injection, not hormonal. Just works to prevent the sperm from entering the semen. And that could be a game changer. That's called Vasal Gel. There's another one called, there's two of them trying to bring it to market. And Contraline, I think, is the other one. So they're both out of the States, but if they could ever get them through clinical trials and bring it to market, it may one day become available in Australia. That would be really great. So, yeah. And put some of it on, men and boys rather than girls having to carry it all.
Absolutely. Anything I can do post-hysterectomy, 37 years old, to help my hormones?
Assume, okay, just to be clear, so hysterectomy is removal of the uterus. Usually, probably this person is talking about the uterus was removed, but ovaries remained, I would think. So there's different, they can do a hysterectomy where they remove the ovaries as well. So just to be clear, if the ovaries are still there, everything from a hormonal perspective is the same as before.
That's great.
Right? Like, the ovaries, you still cycle, you still ovulate and potentially have PMS and go through the cycle. There's just no bleed, right? Because there's no uterus. So all the same treatments that I discussed in Period Repair Manual still apply for the other symptoms. So that's if the ovaries are still there. Yeah. If the ovaries have been removed, that's menopause. That's surgical menopause. And almost always with surgical menopause, you need some kind of hormone replacement. You can't make hormones anymore. There are no ovaries to do that. And in fact, the hormones, even with natural menopause, where the ovaries are still there, but eventually stop, like they are with me at 50, they don't shut down completely. The ovaries still do make a little bit of estrogen, and they're still, it's an easier ride basically than surgical menopause can be, with the ovaries removed, can be quite rough.
Yeah, so taking hormones is really the only answer.
Yeah, and I have a blog post. You're gonna have like a long list of like 10 blog posts.
No, that's good.
A blog post called 4 Things to Know About Body Identical Hormone Replacement Therapy. So there's basically, in a nutshell, for menopausal women in Australia right now, probably the best combination, I'll just say it, is Estradiol, something similar, like a patch, what's called body identical or natural estrogen, combined with Prometrium, which I mentioned earlier, for heavy periods, and even if you don't have a uterus. So Prometrium is important that natural progesterone is important to help protect the breasts, basically, and has other benefits. Yep.
Recovery for hypothalamic amenorrhea, normal BMI, no significant factors other than anxiety. It's
almost always about not eating enough to keep up with activity. I know, yes, it's true. When we were speaking earlier about how stress can play a role in illness and other things, yes. But what the research shows is it's pretty much usually about energy intake. So even with a normal BMI. So I guess short answer is it's usually, but if it's definitely hypothalamic amenorrhea, it's usually about eating more, including carbs. I don't know if there might have been a low carb or some kind of background situation in this case, and just for what it's worth, I have some Instagram posts about this. If you're trying to decide if it's PCOS or hypothalamic amenorrhea, especially if you're under 30, because hypothalamic amenorrhea is more likely to happen under 30, under 35 probably. Yeah. You can look at the ratio between FSH and LH, those two hormones. It's real. I find it extremely helpful. And hypothalamic amenorrhea typically has low LH, luteinizing hormone, compared to FSH. And if basically, with my patients, if I see that low LH compared to FSH, it means they need to eat more. They just need to eat more than they're eating. And it's regardless of BMI almost, although a situation would be unlikely to occur in someone who's actually overweight. But yeah.
That's a very simple solution. I like it.
Yeah.
Does getting your tubes tied affect your hormones?
Not officially. I mean, no. I guess the answer is no. There's a little bit of research that maybe lowers progesterone levels a little bit, possibly just because of reduced blood circulation to the ovaries, maybe, or so lots of things we don't fully understand about the body. But short answer, no. You should just keep cycling normally. Yes.
But obviously, if someone's had their tubes tied and now they're having some symptoms, potentially there's a cause and effect there, and they would just address the symptoms based on stuff in your period repair manual. Like, look at
they could look at, especially if they're in their 40s, they could look at maybe taking some progesterone. Yes.
Yeah. Cool. How to bring back your period while still breastfeeding?
Oh, okay. Yeah, that's a bigger topic. I mean, it's just so different for everyone. It's because of prolactin. It's a normal response that the hormone prolactin while you're breastfeeding suppresses periods.
Your body's going, you fucking crazy woman, you do not want to have another baby now.
Yeah, your body's trying to keep you from having another baby. So I don't know that you need to override it specifically. Like I don't have any techniques for, it's different. I mean, I know some women do get their periods back even when they're breastfeeding. It just really seems to be how you're calibrated. And so, no, I mean, I guess I would say make sure you're eating enough, which you should be anyway while you're breastfeeding. Yeah. But if your body's just decided, it depends on, a lot of it depends on the frequency of breastfeeding, right? So more frequent breastfeeding is more likely to suppress periods. But if your baby needs more frequent breastfeeding, then that's what you do. It's okay to have no periods while you're breastfeeding.
Yeah. Help with weight gain at that time of the month. So sometimes I go put on 2 to 3 kilos around my period. Any ideas around what that might be attributed to?
It's fluid.
Yeah. And that's just tough luck and
it's fluid. It's usually a histamine or mast cell reaction, kind of like I talked about earlier.
Get rid of dairy, see what happens.
Well, not necessarily gluten. Gluten wouldn't necessarily come into that. Gluten only really comes into a few things. I think most people are okay with gluten, actually. But I think, look at removing cow's dairy. And the 2 supplements, and I'm just going to mention them, but do be careful because they both have, cautions around them. So 2 diuretic type supplements that can help with the fluid retention of PMS is iodine. There's a big section about iodine in my book. It's not safe for everyone. And vitamin B6, which is one of my favorite supplements for PMS. One of the reasons it helps is it helps with remove fluid retention. Yeah,
awesome. This has been amazing, Lara. I will let you go because I don't want to take up your whole day.
Yeah.
But thank you so much. I will put all of the notes as to where people can find you and all of these amazing blog posts where they can get your book and all that sort of jazz as well. This will actually be up later on today. So.
Oh, wow. Oh, you're fast. Yeah. Okay,
easy. I'm being very efficient at the moment. While I'm dying of the flu, I thought I might as well actually
just put it out there.
Because I might be dead tomorrow. I don't have man flu though, so I probably won't die. But
no, I think you're okay. Well, tag me. Yeah, I'll try to share. I mean, I'd love to. Yeah, if you make an image or something on Instagram, I can put that out. I'm sure people would like to
absolutely do that. Is there anything else you would like people to know? And Instagram, is that mainly where you hang out?
Yeah, so my blog is larabriden.com. All of my social media, which is Facebook, Twitter, and Instagram, is at Lara Briden. And you can ask me questions there. I do tend to sometimes answer some of those questions. And I guess my final message is it's probably easier than you think. I know there's going to be some of your viewers sitting there thinking, okay, well, that's all fine and good, but whatever it is, my period problem is just that much worse, or I'm broken in some way, or this isn't going to work for me. That is not my experience with thousands of patients. Is these kinds of things work for almost everyone. I mean, there are a few very small number of exceptions where maybe people aren't going to get results from something like this, but it's rare. Even the endometriosis sufferers can find another way, usually, than contraceptive drugs. So it's there for you if you want it. It's trust your body.
I love that, Lara. That's really, really good, because I do think people get really overwhelmed, particularly when they've tried lots of things and they've been on all of the tablets and pills and stuff like that, and they just feel like it's so hard. I also just feel like if it means 3 months of removing dairy or something like that, just to see if that moves the needle for you, give it a shot. Or having to take a zinc tablet every day, give it a shot. It can't hurt. It can only be good.
Yeah. Be careful with zinc though, because if you take it on an empty stomach, it can make you feel sick to your stomach. Just one final word in terms of it can't hurt. Zinc is generally very, very safe, but you do need to take it with food. So just as an example. Oh, you've done that.
Been there, done that, almost threw up on myself. Wasn't good. Wasn't a good look. Awesome. Thank you so much.
All right. Lara. Thanks, Jen. Okay.
Thanks so much. Okay.
Bye.